Going to move us along to our next panel. Our next panel is being facilitated by Rick Berke. Rick is the founding executive director of STAT, which is a Boston-based national publication about health, medicine, and life sciences. For those of you who are in Boston, you know this, but STAT has burst on the scene really a couple of years ago and has become one of the most interesting, reliable sources of reporting about health nationally. Rick previously was a reporter and editor at the New York Times, where he was White House correspondent, chief political correspondent, Washington editor, and a variety of other titles. And more recently, he was also executive editor at Politico. He has degrees from University of Michigan and from Columbia University. Rick.
Thanks very much. I just want to commend BU and the Lancet just for hosting this event, because there's so many symposiums and events on health and medicine and science, but this is the first one I've seen that talks about the Trump administration right head on and the impact. And I think it's really I commend you for taking it head on in a nonpartisan way, partisan or nonpartisan. It's an important issue in our day. And I also wanted, and thank you for your kind words about STAT. I wanted to offer you something. If you'll indulge me for 2 seconds, we have this new service called STAT Plus. It's about 1.5 years old for people really that want to go even deeper in health and medicine. And it's normally $300 a year. But I just asked our people, I said, can I give them a discount for our academic people who don't want to spend $300 a year? And they said, have them type all caps academic 50 in our special when you sign in, and you can get it for $50 a year, which is really a great deal. So academic 50, and you can read STAT on the cheap. So I'm really, as a former political reporter, I'm really anxious to get the conversation going after our speakers come up here, and it really is a powerhouse panel, and I think their bios in here speak for themselves. So let me just first introduce and cross my fingers that I pronounce this right. Atheendar Venkataramani is our first speaker. Where are you? Oh, there you are. Did I do it right? Oh, okay. Well, anyway, assistant professor of medical ethics and health policy at the Perelman School of Medicine, University of Pennsylvania. Come on up.
Sure. All right. Well, thanks. I have a timer here. It's perfect. Thank you all for having me. I really appreciate the opportunity to talk about this topic. It's a very large topic, so I'm going to do a pretty selective kind of dive into this, and hopefully it's to set the stage for the conversation we'll have later. All right. Did I? Oops.
Green button.
Green button? There we go.
There you go.
Great. So a few stylized facts about the economy. So the black line here is the unemployment rate. And as you all know, unemployment rates are at their 18-year lows. So this is good news. On the flip side, though, the dashed line is labor force participation. And that's been declining steadily since the turn of the century. And labor force participation in particular has declined a lot among men, particularly men with some college education, high school education, or less. Another stylized fact that I think is important to kind of frame our discussion is income inequality in the United States. So on the x-axis, we have income inequality, well, we have time from 1920 to the present day. And on the y-axis, you have the share of the total income held by the top 1%. If you drew this for the top 5%, the Gini coefficient, you'd see something very similar, which is that there was a high degree of inequality in the early part of the 20th century. It declined substantially in the post-war years and started rising again around 1980. Here's another stylized fact. So on the x-axis here, we have the income of parents. And on the y-axis, we have the likelihood that the child will attain an income that is better than what their parents had attained. And each line is a different birth cohort. And what you notice is that the prospects for upward mobility, measured in this specific way, have declined over time, over the last several generations. And there's also pretty wide spatial differences in social mobility across the United States at the county level. And we also know that social mobility varies a lot by race. Some cross-cutting forces that might explain some of the trends that we're seeing, but also I think are important to mention on their own. And a lot of it has to do with what's happening to work. So especially the manufacturing industry, but more generally jobs that are routine and manual have tended to, in the last several decades, to become less prevalent. And the thought is that rising automation from robots, as well as, with a lesser extent, foreign trade, have basically displaced these jobs from the current labor market. And in this setting, skilled workers, those with more education, have tended to do better. So what are some population health consequences we should be thinking about? So the first thing to note here, more stylized facts. On the left-hand side is changes in life expectancy at birth from 1980 to 2014. And what you see is that, I think the red scale, the darker it gets, the worse it is, meaning there is little change or even in some cases a decrement in life expectancy. So there are a number of counties in the United States where life expectancy changed little or even declined. On the right-hand side is a graph that looks at income on the x-axis and on the y-axis life expectancy at age 40. And these are for a number of different cities. This graph makes 2 points. The first is that, as we know, life expectancy rises with income. And the second point is that a lot of the variation that we see in life expectancy is at the bottom of the income distribution. And work by Jacob Bohr and others has shown that the relationship between health, if you measure it as life expectancy, and income or socioeconomic status more generally, has only strengthened over time. Another feature that I think is less well known is that social mobility, net of other features of counties like income inequality, county income per capita, health services, is also strongly associated health, both in the cross-section. Here we have mortality on the x-axis and upward mobility increasing as you go towards the right, on the x-axis, and mortalities on the y-axis. It also matters over time. So I think a few speakers brought up the Case-Deaton findings about rising white middle-aged mortality. And one of the actually the only predictor that we found for areas that that saw the biggest rise in white middle-aged mortality was the level of social mobility. So low mobility places saw a greater increase in mortality in this particular age group. And then this is some work by, there's a number of people working on this, looking at the effects of trade and job displacement on working age mortality. And what you see is, on the x-axis, as there's greater exposure to trade at the commuter zone level, mortality has also tended to increase. And some of the deaths of despair that we've been talking about, so suicide, opiate and drug use related mortality, and mortality from alcohol use disorders, have also increased in the setting of increased exposure to trade. So thinking about the economy, what have been the dominant policy responses by the administration so far? And we can talk about 4, and I'll spend a little bit more time on the first one. So the signature act of the administration was the Tax Cut and Jobs Act of 2017. And so the motivation behind this act was this typical kind of supply-side motivation that we've heard in the past, which is reducing taxes can basically induce economic multiplier effects by putting more cash in the economy and stimulating increased investment that can grow productivity for everybody. It's important to kind of think about the Tax Cut and Jobs Act in the context of what taxes have looked like historically for us. So again, this is a graph that goes from 1900 to the present day, and we're basically plotting the marginal income tax rate. And this is actually for a number of countries. The United States is in there in gray. Actually, it turns out to be the hardest one to see. But what basically we see is that since 1960, 1970, the marginal tax rate for the top has declined. And the Tax Cut and Jobs Act has more of that embedded in it. So the biggest absolute gains will be in the top of the income distribution. So one concern that people have, and this is for anything that may increase income inequality, is that by further spreading the income distribution, it creates opportunities for capture of political institutions, which can change public investments and can potentially continue this cycle of increasing dispersion. So that's a political economy feature that we need to track and be careful about. Another response has been protectionism. And this is the idea that trade has displaced people's work and has made them unhealthy and has created despair. And so the Trump administration has been pursuing tariffs, trade restrictions, there's a lot of rhetoric around this, as well as immigration policy. And we know what some of the health effects of immigration policy might be from Dr. Saadi's talk. As far as trade and trade tariffs, it's unclear what the effects will be sort of at a population level. It's entirely possible that certain kinds of protectionist policies can actually contract economic opportunities at a spatial level. It can make some consumers worse off through rising prices of goods. But again, this is something that we need to track. I'll mention one more thing, which is safety net reforms. So this, I think Adam is going to talk more about the healthcare system, but one thing that we're starting to see in the Trump administration is basically tying labor force opportunities and social safety nets. So one example is work requirements in Medicaid. And the idea is that for people who are proposing this is that policies, safety net policies can potentially create disincentives on the margin for people to engage in work. And so there is some literature from the SSDI program which showed that as disability availability rose, labor force participation declined. The other thought is that this is a kind of a developmental model, which is that people engaging in the safety net, this is an opportunity to try to get them into the labor force, especially as labor force participation has declined over time. Of course, on the other side, the concerns are that these programs, that disincentive effect is not as large as we think it is, and that potentially there's, these programs will not be targeted towards the able-bodied people they're supposed to target, but may actually target people who are out of work for good reasons. So I'm just going to talk about other policy options that really haven't come up, but are at least in the administration's agenda, but are out there. I'm actually going to start with minimum wage, which got chopped off of the slide, but as we know, a number of cities are pursuing minimum wage policies to increase minimum wage to $15 an hour. On the plus side, there's a whole literature that suggests that minimum wage increases haven't reduced labor market opportunities, either at the, either having a job at all or the number of hours worked in our history thus far. But on the negative side, there's some data coming out of Seattle that suggests that employers may be scaling back some of the hours people could work as a result of a wage increase there. But different cities are doing this now, and we're going to start collecting a lot of data on what it might be on what the economic and health effects would be. Okay. Earned income tax credit is something that has bipartisan appeal. It focuses on people who are at the second, third, and fourth deciles of the income distribution who may not necessarily qualify for some of the safety net programs, but may be facing economic risks in their lives. There's good data to show that it can spur labor force participation, and it's actually been tied to health, particularly of infants who grow up in households whose parents benefit from this policy. Increasing access to education comes from our historical experience. So I showed you that big dip in inequality in the post-war era, and one explanation for this is that the United States was a leader in investing in education at that time, and so that the US was winning this race between education and technology, as Golden and Katz put it. And so one thought is that as the skill requirements to participate in the economy rise with automation and trade, that getting people educated is an important step. Early childhood investments have a lot of both bipartisan support, and they also have a lot of evidence around their long-run effects on people's health and economic mobility. Safety net innovations, I'm just going to mention one. A lot of people are talking about basic income. I mention it because I've heard people on both sides of the political aisle be very interested in it. And the idea is that everyone would be guaranteed to some type of income that would allow them to live, and this is one way to hedge risk against these kinds of shocks, like, oh, your job is going to be one day automated by a robot, and so here's something that'll catch you. The evidence for this is forthcoming. So there's a big trial now that's being done in 4 cities in the United States looking at basic income and its effects on kids. We do know from historical experience, though, that the results were mixed from the negative income tax experiments of the 70s. So looking in the short and long run, it's not clear whether these were real panaceas in expanding the welfare of people. Financial risk reduction, I just will mention that quickly. You could imagine that we all could face a risk that our jobs will be automated someday. And so you might think about buying or creating an insurance policy against that risk that you would buy now, and so that in the future, if you lost your job because Johnny 5 or some other robot took it from you, you would be able to have some kind of income thereafter. And Bob Shiller, who's a Nobel Prize-winning economist, had proposed this, and it's something that ex ante we could consider as well. I'm just going to lastly mention here social policy as well. We don't think about it as much, but when I talked a little bit about social mobility earlier, the most recent striking fact about social mobility is that there's a huge gap between white and black men and their prospects for upward mobility that does not exist between white and black women. And so it suggests that it's more than neighborhoods, more than the common investments we're making in all children, but it's something specific about how labor markets and societies are basically treating certain sets of people. And so some of the clues that we may need to restore the American dream for all people may actually exist in the social world, and we can't ignore that. I'm going to actually end on something that, okay, depending on which line you look, could be kind of depressing or not depressing. So I showed you earlier the relationship between trade and mortality. So in some of the work that we're doing now, we're trying to figure out, are there counties that respond differently? So here, in a latent class model we did, we found two sets of counties. We had counties in the blue that we call trade sensitive, and counties in the red, which are trade immune. And on the x-axis is the degree of exposure to trade, and on the y-axis is the change in mortality. So as you can see, in trade-sensitive counties, mortality tended to go up as the exposure to trade increased, but there was no such response for these trade-immune counties. And the interesting thing is, how are these counties different? So they're different in the ways that are going to be predictable to you in some cases. So trade-immune counties, rather, have more college graduates, for example. They're also different in the ways that I think the political left would probably predict. So the trade-immune counties tend to have higher per capita spending at the county level. They tend to be located in states that have more generous welfare programs. They're also different in the ways that I think conservatives are interested. So counties that are trade immune tend to also have families that tend to stay intact, which is a big conservative talking point about social mobility. So the point of showing this is that it's possible that even as our economy changes, we can do a better job of decoupling health from that. And even in our past experience, we see that that's possible. And trying to really understand the policies that allow us to do that, I think, will really require a bipartisan conversation, a lot of data, and I think really novel methods to look at. All right. You know, I do have 30 seconds, so I'm just going to finish with this. We can't ignore the fact that health could actually influence economic policy too. So on the left is a graph by Jacob Bohr, which looks at changes in life expectancy on the x-axis along with support for the current administration on the y-axis. And basically in places where life expectancy did not experience the same kind of secular decline, support for the current administration tended to rise. And on the right-hand graph is going back to this idea of trade immune and trade sensitive counties. On the x-axis, as you go forward, it's more likely that you're a trade sensitive county. And on the y-axis is the swing between President Trump and then candidate Mitt Romney. So places that tended to be trade sensitive were also the ones that tended to swing more Republican in this election. And the political regime obviously has a lot of effect on the economic policy that we undertake. So these feedback loops are really important to keep in mind. Thanks so much.
22 seconds to spare is really impressive. Our next speaker, when I mentioned her to the editor who sits next to me yesterday, she said, "Oh my God, do you read Marion Nestle's blog, her food blog every day?" It's like huge fan base that Marion has. And she's here to talk about Trump policies on food and nutrition. And Marion, are you? Thank you.
After hearing the previous talks, I'll just say it's just a privilege to be here and to be included among you. Thank you for the talks that you gave. My task here is to talk about Trump policies on food and nutrition. And after hearing about immigration and opioids and race and the other issues that I've talked about, food may seem trivial in comparison, but it affects all of us, and it raises the same kinds of issues that the other areas do, in perhaps a way that's easier for people to understand sometimes and seems less threatening. So here's my summary of what the Trump administration policies on food and nutrition have been. We see a lot of nitpicking, what I mean by that is things that seem absolutely trivial, and you're going to wonder why I'm even mentioning them. Saber rattling, because we don't know what's going to happen yet. But there's been a lot of threats. General lack of transparency, which is why we don't know what's happening, and in general, tremendous support for the food industry over public health, supporting corporate rather than public health, and what we don't know is the extent of the lasting damage. Now, in order to understand this, you need a little wonky stuff. There are 3 agencies in the United States that deal with food and nutrition policy. The main one is the Department of Agriculture, which for historical reasons not only supports production, industrial agriculture, but also food assistance, nutrition education, and various other things. The FDA, which deals with what's on package labels and food safety, and the Federal Trade Commission, which deals with food advertising, which I'm not going to talk about. So the 2 main ones are USDA and FDA, mainly USDA, and what's going on in USDA is so shocking and so distressing that the Union of Concerned Scientists published a report a few months ago calling the Department of Agriculture as transforming into the Department of Agribusiness. The easiest explanation of what's going on there is to take a look at who is being appointed to Department of Agriculture positions. And this particular cartoon shows 4 lobbyists for food trade and food business associations, agribusiness associations, who have been appointed to positions in the Department of Agriculture where they're either working on or advising on exactly the issues that they lobbied on before they joined USDA. The most recent nominee for the Undersecretary for Food Safety, an extraordinarily important position, is a woman who got most of her research money from the Beef Products Association, and in a lawsuit some years ago over lean, finely textured beef, which has been pejoratively called pink slime, she testified for the company that it was meat, it was beef, it was nutritious and entirely safe to eat. This is our new, the nominee for secretary, for the chief food safety officer on the meat and poultry side. And to talk about why this is important, I need to just state the obvious, which is that food is really important to public health, and that food and nutrition issues there are 3 of them. One is undernutrition, which affects about 1/6 of the world's population, hunger and malnutrition. Overnutrition, obesity and its health consequences, which is believed to affect at least 1/3 of the world's population. And the impact of our food production and consumption system on greenhouse gases and climate change and the environment in general, which affects absolutely everybody. Therefore, a sensible, healthy food policy would promote food systems that promote food security, that promote nutritional health, and that protect the environment. That's just stating the obvious. That, however, is not what's happening. So let me say something about each of those. On the food security side, 2 of the main programs that are dealing with food security are SNAP, the Supplemental Nutrition Assistance Program, which has 42 million participants at a cost of $68 billion a year, making it a prime target for budget cuts. And politically, it is embedded in the Farm Bill and accounts for 80% of the spending of the Farm Bill, which is very complicated politically. A second one is school food, which affects 30 million children at a cost of $13 billion also. And I'm not talking about WIC and some of the other food assistance programs that are very important for individuals, but are much, much smaller. To start with, the Department of Agriculture announced a few months ago that it was going to name a Chief Integrity Officer for Public Nutrition to ensure that food programs were efficient and were serving those who were truly in need. And that requires a translation. Efficiency and in need is a euphemism for budget cuts. And integrity is a euphemism for preventing fraud. So an enormous amount of Department of Agriculture effort is going to go into preventing fraud in these programs that are so essential to people. In January, the new Secretary of Agriculture, Sonny Perdue, announced that he was going to start working on restrictions in the SNAP program. In February, they announced that they had a new method for dealing with food assistance. They were going to give people harvest boxes that would use USDA supplement surplus food commodities to give to people rather than the electronic benefits that they have now, or that they can spend on anything in a grocery store. This was immediately derided by the public health and lots of other people in the community, questioning the details of how this would work, how the logistics would work, and criticizing the fact that there would be no fresh food and no choice in foods. And the harvest box did not turn up in the Agricultural Appropriations Act that was passed, but it hasn't gone away. And the Politico had made this wonderful statement that it was Blue Aprons, had a socialist, it was Blue Apron with a socialist hangover, and more about the welfare of agribusiness than the poor. But at the end of April, Sonny Perdue was still talking about the importance of the harvest boxes, so they haven't gone away yet. We heard a little bit about this earlier. This is the Homeland Security Office, which announced last year that foreign nationals, even those who were legal even those who were legal residents, they want to make sure that they have adequate means of support and will not end up on welfare programs and freeload on public benefits. And that has trickled down into the immigrant community, so that, spooked by Trump proposals, immigrants are abandoning public nutrition services. This is one way to get the roles of nutrition services depleted without having to do anything, and they're dropping out voluntarily because they're terrified that they're going to get turned over to Homeland Security. And then there are the work requirements that we heard about for Medicaid. They're also being proposed for SNAP recipients, even though federal agencies like the Office of Management and Budget have estimated that it won't be possible to develop the kind of work support programs that will be needed for the large number of participants in these programs. But the idea is that they would have to work full-time or be in training for 20 hours a week. Who's going to do that training? Nobody said. Okay, that's on the food insecurity side. On the nutritional health side, the dietary guidelines for Americans say that we're supposed to be eating more fresh fruits, vegetables, lean meats, dairy products, real food, as opposed to junk food, processed and highly processed foods. The dietary guidelines are required by Congress to be redone every 5 years. These dietary guidelines came out in 2015, and so the Department of Agriculture, in conjunction with the Department of Health and Human Services, is now working on the 20 to 25 dietary guidelines, a process that is going very slowly. It's a four-step process, beginning with a call for ideas about what kinds of questions should be asked, and that will be followed by appointment of the advisory committee that will actually develop the research report for the guidelines. The issue of who goes on this committee is a very important one, because Mr. Trump has just appointed to the President's Sports, Fitness, and Nutrition Council the only person who has any nutrition qualifications at all, who is Dr. Oz, a long-time purveyor of medical misinformation, and who has been written about in various journals of medical ethics. Big issue there. On the school food side, there's been a rollback of Obama-era school food rules to make the school food healthier. It's very difficult for me to understand why school food isn't a bipartisan issue. Doesn't everybody want kids to eat healthfully? Apparently not. So the Trump administration is allowing more sugary chocolate milk, fewer whole grain foods, and more sodium a day. This is nitpicking. Very hard to understand why this matters. But the attitude of the Secretary of Agriculture is very pro-industry. And he argues that kids won't eat the meals if they don't taste better, although there is vast amounts of real evidence that more than 80% of schools were able to implement the Obama-era regulations without any trouble, and the kids were eating the food. This brings me to the Food and Drug Administration, and this is interesting because the commissioner of the Food and Drug Administration is getting lots of plaudits from the public health community for not being terrible. His attitude towards what he's doing in the FDA is very pro-industry. In 2017, he made the statements that he wants to make it easier for industry to meet their obligations in menu labeling. Yesterday, menu labeling went into effect nationally to great applause, but he announced something that he calls flexible options for compliance. That's a euphemism for you don't really have to comply with this. You can find some way to get around it. On his blog, he calls his blog FDA Voice, food information that's pro-market and pro-consumer. It's the pro-market part that troubles me, because there's a quid pro quo in the menu labeling proposal, which is that he is encouraging science-based health claims on food products. That is another euphemism, which means, because there's no such thing as a science-based food claim on a single food product, so that's another euphemism for letting food companies market their products using health claims. And then, again, this may seem like nitpicking, but the Department of Agriculture has removed an enormous amount of data from its website. And this was an article by the Skeptical Inquirer, somebody who used the Department of Agriculture's database to look at the nutritional quality of food consumed away from home in restaurants and in packages as compared to food at home. And he shows what the website looked like in December 2016 as opposed to what it looked like in March 2018, with an enormous removal of data on American food consumption habits. So that's what's happening in that area. On the environmental impact side, one of the things that makes nutrition easier to talk about is that the diet that is recommended for health is also the diet that has the least impact on climate change. That is a diet that's largely plant-based, because meat production has an enormous impact on climate change. And the environmental impact brings us to the Farm Bill, which is in play right now. And the Farm Bill, for those of you who aren't familiar with it, and most people are not because it's really complicated, was described by President Obama as a Swiss Army knife. I don't exactly know what he meant by that, but I think he meant that it does a lot of things and doesn't do any of them very well. In any case, the Farm Bill is supposed to support America's farmers, and America's farmers are in crisis right now. There's too much food in the world, prices are very low, and they're in big trouble. There's huge worry that the Trump administration is going to crash the farm economy. I once heard a Department of Agriculture official say that he didn't think that we should grow food in the United States at all. We should be letting third world countries grow our food. It would be much cheaper. So there's big concern that Trump has sold out the family farmers. Some of this has to do with trade policy, where by imposing tariffs on products from China, China has retaliated. And that's a list of all of the foods, the producers of food in the United States who are going to be affected by that retaliation. It's lots and lots and lots of small farmers. The Trump administration is also attacking the organic standards and has killed the rules for organic eggs, has allowed substances to be included in the organic rules that the Organic Standards Board voted against, and is abandoning welfare standards for organically produced animals. The one bright light was that the Department of Agriculture denied the poultry industry's request to speed up the speed of slaughter lines, but that's because they grant lots and lots and lots of waivers, and there's evidence that 20 companies have already been allowed to run these birds through the slaughter line at 175 birds per minute. Just think about that. No, don't think about it. And I'll sort of end this with, I don't know, you can't make this stuff up. This is my favorite of the Department of Agriculture's proposed labels for GMO foods, for genetically modified foods. I'm not arguing that this has public health effects, but BE means bioengineered, and you get it with a smiley face. Can't make this stuff up. So the question we have to ask is, how much damage is this causing? How much damage are we going to see? We don't know that yet. So I think this is a time for advocating for food systems that will promote food security, promote nutritional health, and protect the environment. We know what those policies are. They're very, very well described. And these are the kinds of things that I talk about in my book. And I didn't do a disclosure statement because I've just written a book about it that's coming out in October. And I have no industry conflicts to declare, to say the least. Thank you very much. What do I do? I sit down.
I think sit and then. Thanks so much. And our final speaker is Adam Gaffney, who's going to talk about healthcare. He's the instructor of medicine at Harvard Medical School, pulmonary and critical care physician, and at the Cambridge Health Alliance. Adam, hi. How are you?
Nice to meet
You too.
Thank you so much for that introduction. Thank you to BU, thank you to The Lancet, and to everybody who is here. So I will be talking about a more narrow issue, healthcare in particular. No disclosures, I am on the board of directors of Physicians for a National Health Program. So Trump was elected with a promise vowing to repeal the Affordable Care Act, although he was not unique in this respect, and all of the Republicans were on board. And from day one, he took several actions to attack the law. In January of 2017, for instance, he ended funding of advertisements as open enrollment came to a close. But of course, the big drama of last year was the Affordable Care Act effort, repeal effort. So Republicans in the House of Representatives succeeded in passing a bill, the American Health Care Act, led by Paul Ryan. And this was a bill that would have really decimated the public health care infrastructure, driving up rates of uninsurance, to greater than, upwards of 50 million. But keep in mind, and that's the red line there over 10 years, that the baseline that he came into office with was quite high as well in terms of the number of uninsured, 25 to 30 million uninsured. The bill made it to the Senate, but as we know, was dramatically defeated ultimately, in no small part due to the activation of large numbers of activists all over the country, as well as a big groundswell of grassroots activism. And ultimately, the repeal effort fell through for the most part. That being said, despite the failure of Congress to pass a bill repealing the Affordable Care Act, the administration has succeeded in achieving some of the same goals outside of the Congress. So let's begin with Medicaid, which we've heard a little bit about in a couple of the other talks so far. So last March, Seema Verma, head of CMS, as well as Tom Price, then head of HHS, before his ignominious fall because of his penchant for luxury flights, sent a letter to the governors of the 50 states, basically encouraging them to submit waivers to CMS that would allow them, so-called 1115 waivers, that would allow states to modify their Medicaid programs. They mention a few things in particular: work requirements, premium contributions with lockout penalties for Medicaid recipients or participants who did not pay, cost sharing, particularly co-payments for emergency room use, so-called non-emergent use of the emergency room. And then they also mention getting rid of certain benefits, in particular non-emergent medical transportation, programs that help people on Medicaid get to the doctor. And this bore fruit rather rapidly. But I should mention that the sorts of Medicaid waivers that we've seen come to fruition were in large part based on what came before the Trump administration. So let's go back a few years to Indiana. Mike Pence is governor. He achieves a Medicaid waiver that dramatically changes Indiana's Medicaid program. This was actually in large part designed by Seema Verma as a consultant. The program created new premium contributions. Medicaid participants of very, very low income who did not pay these contributions were either kicked out of the program or not allowed to enroll to begin with, and then locked out for a period of 6 months. Or for the very poor, they were able to stay in, but they had their benefits downgraded. In particular, they would lose dental coverage and coverage of vision care. The Lewin Group did an analysis of the Medicaid waiver over about 2 years, looking at what happened as a result of this sort of program. And what they found is not surprising. More than 280,000 participants, that's the bar all the way on the far right, had their coverage downgraded. Again, losing dental coverage, vision coverage, and getting new co-payments. They were downgraded from HIP 2.0 to something called HIP Basic. HIP is Healthy Indiana Plan. And then almost 60,000 Medicaid participants were either disenrolled from the program and not allowed to re-enroll for 6 months, or never got enrolled to begin with because of these requirements. So this was just the beginning of a new era of Medicaid reform. There's been a number of waivers that have been approved by this administration that do all sorts of things. Premium contributions with disenrollment, as I mentioned. Work requirements. 3 states have gotten waivers that allow them to impose work requirements on Medicaid participants. More on that in a moment. But other states have gotten things, including Kentucky, co-pays higher than statutory limits, penalties for missing appointments, excluding medical transportation, and various wellness incentives, but really penalties for people of poor health. Now, Kentucky has probably gotten the most coverage. Kentucky had a very successful Medicaid expansion under the Affordable Care Act. And in January, it was the first state to get a waiver that allowed it to impose work requirements. So what are these work requirements and who are they supposed to be designed to impact? Well, it turns out that the vast majority of adults receiving Medicaid are actually already working, or if they're not working, have good reasons not to be. So this analysis from the Kaiser Family Foundation shows that 60% of adults on Medicaid are already working, and of the 40% who are not, they have good reasons in school, caregiving, or have illness or disability. But really, to a cynical perspective, to a cynical mindset, which I certainly have in this regard, this isn't really about encouraging work. This is about pushing people out of the program. It's another layer of bureaucracy. just to give you an example of another provision in the Kentucky Medicaid waiver, the program imposes or sets up two sorts of accounts for each participant: a high deductible health account with $1,000. Healthcare expenses get pulled out of that account. And that encourages people not to use healthcare because whatever's left over gets rolled over into a My Rewards account that they then can get various complicated penalties for, and what's left over in that account they can use to cover things like vision care and dental care, which in any sane and just world would be covered as part of a universal public health care program to begin with, as opposed to this sort of Rube Goldberg nonsense. Now, again, but the effects of all this is to push people out of the program. It's really not that complicated. In fact, in Kentucky's own waiver application, its own 1115 waiver application for the program I'm talking about, they actually estimated that there would be large reductions in program participation 5 years out as part of their budget analysis, sort of in the fine print. It wouldn't affect children so much, but adults, they estimate 95,000 fewer participants 5 years later. So there's a lot of surface complexity to these waivers, but again, the way I view it, pushing people out. So achieving some of the same aims as the repeal of the Affordable Care Act, even though that fell through. All right, there's other waivers coming down the pipeline. Actually, this slide is a little outdated as of yesterday. So 5 states requested caps on duration of Medicaid coverage, basically meaning, you only could be on Medicaid for 3 years and then good luck, figure it out yourself. That was actually even too much for Seema Verma, so they've rejected Kansas's application for this yesterday. But one state has requested drug testing as part of its waiver. You have to pass a drug test to get Medicaid benefits. Which makes sense to nobody who knows anything about about the need for substance abuse treatments or anything else, and other things. So that's the Medicaid waiver situation. Again, achieving some of the same aims as the Affordable Care Act repeal. I'm going to shift gears for the next 5 minutes and talk about the changes to the marketplace landscape. So last April 2017, CMS issues new rules, does a number of things, one of which is to shorten the open enrollment period for the Obamacare marketplaces by about half, the time you have to sign up for insurance. And then subsequently, it does a couple other things. The administration does a couple of other things, getting rid of the Navigator program that helps people sign up for coverage, and also reducing the advertising budget for outreach. And then in October, it takes a few more steps. An executive order that encourages, that's designed to encourage the growth of short-term health plans and something called association health plans. And then also the administration ends payment of these cost-sharing reduction subsidies, which I won't get into too much. That had sort of paradoxical effects for very complicated reasons. It actually wound up making insurance more affordable for lower-income people, but it did drive up premiums, which made it less affordable for higher-income people. But what about these short-term health plans? Well, short-term health plans are really just garbage insurance. ACA-compliant plans are often not great either. They have very high cost sharing, more than $10,000 out-of-pocket limits for a family plan. But the short-term health plans are basically oftentimes close to useless if you actually get sick. Not only that, they can risk adjust, meaning they can charge you higher premiums for being a woman or for having pre-existing conditions. They don't have to cover essential health benefits. You don't have to cover pre-existing conditions. A recent analysis of these short-term plans found that more than 40% didn't cover mental health, more than 60% didn't cover substance abuse, more than 70% didn't cover prescription drug use, and not a single plan covered maternity care. Nothing important. So what's going to be the end result of all of this? We don't know yet. The Urban Institute has done a micro-simulation sort of modeling the potential effects of these various policies. And it has estimated that, on a prior law next year, without any Trump never came to power, we would have 28 million uninsured, which is still a gigantic number and still really staying in the national conscience. But it does estimate that as a result of these policies, the number of uninsured will increase to 34 million. And then if you incorporate short-term health plans and the growth of short-term health plans, and don't consider those actual insurance, that there will be closer to 35 million, 36 million people uninsured in 2019. These association health plans, which I mentioned briefly, I won't speak too much about them, other than to say basically these are plans that exist now that are offered by associations of trade groups or small employers. The fear with these is that by expanding their use and sort of deregulating them to some extent, you'll pull some people out of the individual marketplaces and cause premiums to rise for people who need those plans. And whereas less sick people will go into these association health plans, 2 million people leaving by one estimate would probably destabilize the market. So I'm going to say a few more words in the last couple minutes. At the end of the year, there was some change affected on the national legislative level. The administration passed a tax bill. Included in that tax bill was a repeal of the individual mandate that basically requires that people buy insurance. The effect of that we don't quite know. The Congressional Budget Office has traditionally estimated that this will have a large effect. Blue line is uninsurance 10 years from now under current law. Red line is uninsurance with the repeal of the individual mandate. And so it estimates, more than 10 million will be uninsured, although it is revising these estimates downward as a result of new research suggesting that the individual mandate may not do as much as people think. But still, it's going to increase the number of uninsured. No doubt about that. Has there been I'm going to close out with the final question, which is to get back to a question asked in the previous talk. What damage has been done so far? So evidence is mixed. There is some evidence that uninsurance rates have begun to climb. This graph shows the reduction in the number of uninsured under the Affordable Care Act on the left. So uninsurance went down by about 6%. From 2013 to 2016, and then it went up by the Gallup poll by 1.3% last year. So if that's true, then that's about 20% of the gains of the Affordable Care Act may have been eroded. A Commonwealth Fund survey, again, these aren't huge surveys, that actually goes out to 2018, to March of 2018, also shows increased in uninsurance rates, particularly among certain subgroups, particularly among Latinos and low-income people. And the National Health Interview Survey, which is the largest survey, the most reliable, and only goes out to September of last year so far, it does not show an increase so far. But I just want to point out that number, where we land up, even if our insurance rates don't go up, is still very high. More than 25 million people uninsured. And if those of us who are insured, so many people can't actually afford to use their uninsurance as underinsurance rises, as deductibles rise, and as co-payments rise. So I don't want to end on too grim of a note. Even though there's been many steps in the wrong direction, last year also saw some exciting moves in a good direction. The efforts by the administration to repeal the Affordable Care Act seems to have had the paradoxical effect of actually activating the citizenry, galvanizing the population, and pushing support for more radical programs that would go well beyond the Affordable Care Act. We actually saw growing support for single-payer bills in both the House and the Congress, and Bernie Sanders' single-payer bill actually won the support of basically all the leading frontrunners for the 2020 presidential Democratic primary. So steps certainly in the wrong direction, but a glimmer of hope as well for a better future. Thank you.
Thanks, Adam. Thank you for 3 crisp presentations. Why don't we have all 3 of you up, and we'll get right to it. So first off, I want to pretend for 1 second, have each of you pretend that the title of this is the Clinton administration and the health of the public. If you had given this presentation, how might it be different? Each of you to speak out. Because some of these trends you're talking about are trends that are over years, and what concerns might you have been raising under a different administration?
I think I would be raising the exact same concerns. I would have changed one slide, which is probably what the administration's response would have been. I think in the Clinton administration, there may have been more expansion of the safety net, there may have been expansion of EITC. But for the most part, these trends in social mobility, the automation of the workforce, their attendant implications on health, and what we might be able to do to decouple health from the broader economy, no different regardless of who's president. And it should matter for the next president and the one after that too.
Marion.
I think there would be a big difference. Certainly, if you use the Obama administration as an example, early on in the Obama administration, there was a White House task force on food and nutrition, on obesity, on trying to prevent obesity. And the recommendations that came out of that task force report were really excellent. They just couldn't do anything of them. They just couldn't do them because every time they tried to do some of them, they were so strongly opposed by the food industry that they couldn't budge, or the Republicans. They were so strongly opposed, they couldn't do it. But at least they were trying and raising the issues. I mean, if we were going to have a rational food and nutrition policy in America, we would link agricultural policy to health policy in a really firm way, and nobody has ever tried to do that, but it really needs to be done.
Yes, I wound up focusing on developments in the last year and a half under the Trump administration, given the theme of the symposium. But you're absolutely right. I mean, most of the themes that I'm talking about are problems that pre-existed the Trump administration. Uninsurance rates, as I said, 25 to 30 million, even if the Trump administration achieves nothing in terms of taking us backward. And several trends have been worsening. Underinsurance, the Commonwealth Fund has been tracking for more than a decade, and it has found that underinsurance, so having insurance but having high deductibles and not really being able to afford to use it, went up to 41 million in 2016. So many of the trends that we're seeing predate the Trump administration. It looks like they're doing everything they can to make those problems worse instead of better. But yes, I would have been outlining many of the same issues.
I heard a lot of grim talk from all three of you about the trends, whether they're Trump trends or what they would have been existing trends in any case. What can you each distill it to the one thing that most keeps you up at night that you're most worried about?
Does it have to be healthcare?
Income inequality, our election campaign laws, I think. If we don't do something about our election campaign laws and have publicly funded elections, the system will never change.
But in terms of food safety and what you like, very specific.
I think like a public health person, that's an upstream way of looking at a downstream problem. Thank you. Getting food into people's mouths is really important, but if you want to set up a system so that they can take care of getting their own food into their own mouths, and in order to do that, you have to have income equity, and in order to have income equity, racial equality, and all of the other things that we're talking about today, you need to have legislators who are more interested in public health and corporate health. It's as simple as that, or as complicated as that.
A lot of things keep me up at night, but one I'll focus on. I mean, one thing I worry about is that with all these attacks on public health care programs like Medicaid, or the privatization of Medicare, you do worry that that these sorts of attacks can delegitimize these programs, so that people, if you're wrangling with a My Rewards account nonsense, maybe you won't think Medicaid is such a good idea. And for those of us who want to move beyond the status quo to a universal public program, those are real threats. I mean, similarly in Medicare, many people on Medicare, it's a good program, but it doesn't do enough to protect people's financially from healthcare expenses. So that is a concern.
I think for me it would be the fact that the American dream varies across space and has declined over time and varies across race.
What's your sense of, first of all, the president's grasp and concern about these issues? If he were here listening, or is he more of a passive player in some ways of sort of some of his lieutenants or his head of the FDA or USDA? I mean, how much do you think he is aggressively trying to undo some of these policies?
I'll start. I think in the case of healthcare, he's mostly irrelevant. Any of the Republicans who have been elected would have had a similar policy, and maybe they would have been a better spokesperson for those policies, and maybe they would have gotten through. I have no idea. I think Trump has added a toxic element to the national discourse on issues of race, and certainly all the things we heard about immigration and other aspects. But from the perspective of healthcare, these are more Paul Ryan's ideas than they are Trump's ideas. This was a Paul Ryan agenda with the Affordable Care Act repeal. It wasn't something that Trump cooked up, when he was, trading hotel properties or whatever.
I think the incredible thing about what Trump has done is to appoint in agencies people whose ideology is to destroy those agencies. And those agencies, for good, bad, or indifferent, were what we had. To try to at least they were something that where there were different points of view that could be reflected, but to deliberately appoint people who are opposed to the purpose of those agencies makes no sense to me. I mean, that's the place where the commissioner of FDA stands out as a unique force, because he doesn't seem to be opposed to the function of the agency. He just likes industry, I think, a little bit too much. Or maybe a lot too much.
I think for the most part, the Trump administration has pursued kind of the standard Republican economic policies, and which we have to evaluate historically in terms of their efficacy in improving income inequality, fostering economic growth, and so forth. The one place I think he's deviated from both sides is with protectionism and trade, and I think there's scholars, policymakers on either side of the aisle that would find that to be a troubling trend if we believe that trade is on average growth promoting.
Are you worried that some of the points that you three have made are sort of obscured and overshadowed by the daily ups and downs going on in Washington, and that you're talking about very important trends that affect a lot of people, and some of these points you've made just aren't getting out there? I mean, are you concerned about that, and how do you break through?
I think I am to an extent. We still read about the economy, the loss of economic opportunity. I think there are issues like health insurance, nutrition that capture both sides and capture the public's imagination. It is distracting to have things come up every day. But if I were worried more, it would be the fact that I don't think the sides are talking to each other, both at a grassroots level or even at a high political level. I think political debate is really polarized. I'm pretty sure that the people who are watching this tend to have a set of beliefs that maybe we all might agree with, and the other side is not watching this. And I think this is happening more and more. And if we're going to make real progress on these kinds of issues, I think there have to be bigger conversations. And both sides have to reach out.
Yeah, I do worry about that, because I think that these longer-term trends are far more important than some of the day-to-day tweets and scandals, which can't be ignored, but pale in comparison to the potential for these big policy shifts to harm human health and life. I do think that we did see with the repeal of the Affordable Care Act that we moved beyond that. But I would like to, I think there is sometimes in some corners of the liberal media, not a little too much focus on the day-to-day and not enough on some of these larger struggles that are really important, the teacher strikes, the healthcare things, and all that. So it's an ongoing effort, I think, that we all have to make to push the most important issues to the forefront of the national discussion.
We're at a public health school here, and as someone who teaches public health, I would say that the concepts of social determinants of health and upstream, downstream are extraordinarily difficult to convey to students. Everybody I know who teaches social determinants of health finds it just immensely difficult. You have to make it personal, and unless you find a personal way to reach people personally. You can have all the conversations in the world across the divide, but that realization has to come that the causes of the problems that people are having occur way, way, way beyond their immediate understanding and feeling and grasping. This is very, very difficult conceptually, and I don't know how to do it easily.
Related to that, I'm curious about your students and how they've changed over the years in terms of what...
They don't read.
And how does that manifest? They don't read what? How does that manifest
They don't
itself?
read long form anything. They're on, everything is electronic. And for people who learned how to teach at another age, it's difficult. That's all I can say. We're trying, but for the electronically challenged among us, it's really difficult.
A note on students, this is totally unscientific, but my general sense from the perspective of medical students has been a big upsurge in progressive thinking about healthcare and racism and all sorts of things. So I've been very encouraged. I mean, I'm not that far out of medical school, but even my cohort versus people who are coming out of medical school now, it's very energizing. It's much more progressive, a lot of activism. So I'm encouraged, even if, they don't read as much long form.
I think I was just a trainee not that long ago, so I was one of the students maybe. But I would say one thing that's been really encouraging with the students that I've worked with is that there's a real interest in getting into new data sets and causal inference and using the kind of scientific techniques that I think that can be very helpful in informing population health. So that's been a nice trend.
We have a food movement in this country, and it's all to the good.
I'd like to hear from the audience, and especially some students that might be in the audience, to see what you have to say about what they just said about you. So, anyone? Yes. Okay. And please identify yourself.
Yeah, I'm not a student, obviously, but there's been a major initiative at Harvard to address racial disparities at Harvard Medical School, and a similar initiative at University of Pennsylvania to form a committee to address the way that the university medical school deals with racism. And the reason that happened is because the medical students at the medical schools under this organization, White Coats for Black Lives, put together a racial justice report card and gave many of the leading medical institutions a B- or lower on racial justice. So I think it's an example of something that many of us in the faculty have been pushing for decades to try to get more response out of these major medical schools, and the student activists were able to do so.
And do you have a specific question for?
No.
Okay. Yes. And remember to identify.
Yes. Hi, I'm Barbara Moran. I'm a science writer. And first, I teach English at BC, and my students still read long form. So there's hope. My question is actually for Marion Nestle. I was wondering if you could talk a little more about school lunches, about the changes in school lunches from this administration, and how can they make changes so quickly?
Well, I'll just say that from my own experience observing school lunches, they're entirely person dependent. And I can walk into a school, and if the school food service people know the names of the kids and it smells good, the kids are eating the food. And if they don't, it's not happening. So you can have as much policy as you want, but to implement that policy at the actual school level is totally dependent on who's in the school. If you have people who think that serving kids healthy meals is God's work, they'll be doing it. And if you think that it's a stupid waste of time, it won't be happening. So that complicates school lunch. So the policies that were implemented through the Obama administration set up nutrition standards for school meals. Whether those are good, bad, or indifferent, we can argue about. I prefer a food-based standard rather than a nutrient-based standard, but they didn't ask me. So but whatever it is, its objective was to have fewer highly processed foods available and no sodas in the schools. This is politics, so there were compromises. Even so, the compromise is better than what it used to be, and there have been great improvements. And to dial back some of those nutrient standards seemed like a step in the wrong direction and gave permission to the schools that were opposing the new rules, permission to not pay attention to them, and that's really what's happened. I'm not sure that's what you were asking. Is that what you were asking? Good, good.
Yes, in the back.
Hi, my name is Jordan. This is directed towards Professor Nestle also. About the harvest boxes, I can think of a few reasons of why they're very detrimental. They seem to strip people's dignity because they're not able to shop for their own foods. Immigrants perhaps can't choose foods that they would like to be eating that maybe remind them of their home country or that they're comfortable with. I was wondering if you could think of other detrimental impacts of this program, maybe mental health problems.
Well, the prototype for the harvest box was the boxes that are delivered to the elderly, a very successful program in which home-delivered meals are given to older people. And the boxes also were modeled on the program for Indian reservations, which is a famous, famous program with a long history in which the foods that were given to people on reservations were largely lard and sugar. And are believed to be greatly responsible for high levels of obesity among Native American groups who received these boxes. I talked to lots and lots of people who received them when they were growing up, and they talked about what they liked the sugary foods that were part of it. They didn't like the others. They traded them. They bartered them. They fed them to pigs, is what I was told. The current program is very, very different and is actually quite impressive. I visited a place where they give out the food, and there are choices, and it's fresh food, and the food is pretty high nutritional quality. So it's gotten very impressive, but people, unless they live in very remote areas, and even if they do, they can select from a long list of foods. It's actually a very impressive program, but it serves a very small population relative to the 42 million who were enrolled in SNAP. So these foods will be USDA commodities, which means block cheese, whatever meats are left over, whatever the government is buying as surplus, and they may not be the healthiest foods in the world. And, I can't imagine logistically how it could work. It seems totally unrealistic. And the Blue Apron example is ridiculous because Blue Apron is expensive. It's $35 for a meal for four or something like that. People aren't going to be able to afford that, or the government isn't going to be able to afford that.
Thank you, and what a great group. Thanks so much.
Please join me.